بسم الله الرحمن الرحيم. My topic for today, or my task for today, is procedural success of left atrial appendage closure using transesophageal echocardiography microprobes. Echocardiography, of course, is the imaging guidance, plays an essential role in the safe and accurate execution of transcatheter structural interventions. Transesophageal echocardiography is the preferred option in the guidance of left atrial appendage occlusion or closure, requiring general anesthesia in most patients, and this is the problem. General anesthesia, it increases the risk of hypotensive periods, respiratory disorders, and the time and cost of interventional procedures. In elderly patients especially, which are most of our patients for these procedures, general anesthesia is associated with perioperative pulmonary complications, neuromuscular block, which may be prolonged in such patients due to comorbid conditions, and the high risk of cognitive decline. The use of standard transesophageal echocardiography probes for more than 60 minutes has been associated with high risk of oropharyngeal lesions, especially thermal ones. Intracardiac echocardiography, or ICE, has been proposed as a valid alternative to transesophageal echocardiography for some structural procedures such as left atrial appendage occlusion to avoid general anesthesia. And the recent arrival of novel micro transesophageal echocardiography probes might represent a very valid alternative to allow a minimally invasive approach while maintaining proper imaging quality. What are the TE microprobes available? Currently, there are two available probes, namely the S83T by Philips Healthcare and 10TD by General Electric. Recently, about 4 weeks ago, Philips Healthcare received the FDA clearance for its new X1140 Mini 3D transesophageal echocardiography transducer. It's mainly for pediatric patients, but it can be used for adult patients as a micro TE probe. These are the differences between the different probes. If I may point, this is the standard one, this is the mini, and this is the micro. And you can see the differences in the shaft, the tip diameter, very small. Here is a very important thing, the elements, the crystals inside each one. Of course, the standard TE probe is a 3D, so it has more than 2,500 elements. The mini has 48 only, and the micro has 32. Capabilities, of course, only the standard has 3D capabilities. The mini and micro probes by Philips and GE have only 2D properties. And this is a comparison of imaging modalities for intraprocedural guidance of left atrial appendage occlusion, standard miniaturized or mini or micro pediatric TE, and ICE intracardiac echocardiography. The standard one, of course, has the best image quality, and the expertise are already available. There are available trained physicians to do standard transesophageal echo. The miniaturized enables conscious sedation, avoids the problem of general anesthesia, and possible decreased risk of esophageal injury. The ICE, it enables conscious sedation also. Single operator, the interventionalist, can do the ICE and can do the intervention procedure, the left atrial appendage occlusion, and of course, patient comfort. Caveats of standard is the need for general anesthesia, as I mentioned before, need for dedicated cardiac imager, which is he or she is exposed to radiation. This is another issue. Patient discomfort and esophageal injury. The mini ones, they need dedicated cardiac imagers also. Lack of 3D until now. We hopefully in the future or the near future will be available 3D and biplane imaging. Patient discomfort is better than the standard ones, but still there is patient discomfort. Risk of conversion from general to general anesthesia. Sometimes the patient cannot tolerate the probe or the procedure is prolonged, so I will have to switch to general anesthesia. The ICE has a steep learning curve. It's very expensive. I don't think it's available in Egypt. You have to do an additional venipuncture and an additional transseptal puncture. Whether we do one single transseptal puncture for the device for the left atrial occluder, but we have to do another one for the ICE probe versus a larger single one for the device. The initial experience was in 2017. It's a Dutch group, but here it's not especially for left atrial appendage occlusion, it's for microprobes in transcatheter procedures as a whole. They concluded that micro-TEE is feasible for procedural guidance. It offers comparable imaging quality, although the number of elements, as we have seen, is less, but it's not very bad, which with a much wilder field, this is very important than intracardiac echocardiography, and slightly reduced but sufficient image quality and comparable accuracy as standard TE. Micro-TE is not associated with any significant discomfort in patients under local anesthesia and conscious sedation. Their findings support the use of micro-TE as a valid alternative option compared with standard TE and intracardiac echocardiography. Further studies are warranted to assess other important potential benefits of the micro-TE, such as shorter procedure time, fewer complications, and more efficient procedural planning and lower medical costs. This was published in the Netherlands Heart Journal in 2017. In 2019, Spanish group published a letter titled Minimally Invasive Transesophageal Echocardiography for Left Atrial Appendage Occlusion with the latest generation microprobe, the initial experience. They concluded that the high patient comfort and the excellent imaging quality suggested that the latest micro-TE probes might represent a very valid alternative for left atrial appendage occlusion and could be an option in patients without anesthesia, without intubation or general anesthesia, in particularly elderly patients, because as we mentioned, these are the most liable to anesthesia complications, especially or with severe comorbidities. And this is the comparison, as we here see the €1 coin. This is the standard probe, and this is the micro probe. This is the images with the standard probe, and these are the images with the micro probe. A little bit, of course, the image is degraded, the image quality is degraded, but it may be sufficient to guide the procedure. And this is, of course, a fluoro with a puncture and the micro probe and the device in place. And this is the micro-TE image of the device in place. In 2023, another Spanish group published an abstract in the ESC 2023 Congress titled Safety and Procedural Success of Left Atrial Appendage Closure Interventions with Transesophageal Echocardiography Microprobes. It was a single-center prospective study which included patients in which left atrial appendage closure was performed between the years 2009 and 2021. They concluded that TEE with microprobes is a safe and effective imaging technique for procedural guidance of left atrial appendage occlusion, with procedural success and the complication rates similar to conventional transesophageal echo. Furthermore, its use reduces in-hospital length of stay, enabling outpatient procedure. You can do the procedure and discharge the patient in the same day. This is the comparison. The standard one, 357 patients, and the micro for 154 patients. You can see that the patients with micro using micro-TE were older, of course, with more comorbidities, and to avoid general anesthesia. No significant differences in other. The procedural length was shorter significantly. The success, no difference. Complications, more or less, no difference. And in hospital stay, they mentioned that it's shorter. But if we look at the numbers, I think it's longer. I don't know why they said it was shorter. If we look at the mid and the mean and the average, it's actually longer. Yes, yeah. They claim that it's shorter. I don't know why. Multi-center experience. Also in 2023, Amanian et al. Published left atrial appendage occlusion under miniaturized transesophageal echocardiographic guidance and conscious sedation, a multi-center European experience. They retrospectively collected baseline characteristics, procedural data, and short-term follow-up outcomes from 546 left atrial appendage occlusion consecutive procedure attempted with miniaturized TEE probes and conscious sedation in 5 European centers between November 2014 and April 2022. The 5 centers, 2 in Spain, 1 in the Netherlands, 1 in Belgium, and 1 in France. And this is the central illustration from their study. This is also the micro TE probe used in about 2/3 of the procedures. Okay, these are the images, these standard transesophageal images, and these are the micro ones, and this is follow-up. Of course, this is CT, and this is 3D TE, but this is follow-up, not during the procedure. Because, as I will mention, 3D planning before the procedure and follow-up is essential for the success. It does not replace totally 3D TE, but it replaces 3D TE during the procedure, not before and not after for follow-up. This is the technical success and procedural success. Complication rate is comparable. And unfortunately, in 3 patients, 0.7% of the study group, they had to convert to general anesthesia because of patient discomfort or prolonged procedure. They concluded that in this large multi-center observational study, left atrial appendage occlusion under conscious sedation miniaturized TE guidance was safe and feasible, with a high rate of technical success and low rate of peri-procedural complications. This mini-invasive left atrial appendage occlusion approach might represent an attractive and readily available alternative, we hope so, to general anesthesia and the standard TE probe, keeping in mind that pre-procedural CT imaging is required to maximize technical success. And thank you for your attention. Yes.
بني ادم ان في حاجه في زوره وبقه ولا حجمها؟ يعني ما هو في الاخر برضه حتى لو حاجه رفيعه يعني
هي اكيد هتضايق اكيد هتضايق، بس الفرق طبعا حضرتك اضرب الستاندرد تي اي بروب بالذات ال 3 دي ضخم جدا. ما يعني
بس هل ده فعلا هيغنيك عن التي اي ان الجنرال انستيزيا
يس
معاك حاجه رفيعه هيقعد ساكت العيان طول الوقت؟
انا عارف، لا انا بس هجيب سلايد عشان اجيب صوره.
بيدياتريك في القدر. من غير اي حاجه. لوكال بس.
المايكرو كمان.
عكس 3
جرين اوف سولت محتاجه جرين اوف سولت.
عندهم 3 دي
مش 3 دي. بالظبط. وفي ادفوكتس او يعني في ترايلز اتعملت على استخدام الايس ترانس اوسوفاجيا. يعني انا استخدم بروب الايس بدل ما ادخل بيه فيني بانكشر، احطه هو ترانس اوسوفاجيا. اكسبنسيف. وفي ابي ترانس نيزل ابروتش، يعني في دخلوا نيزل مش اورو فارنج، نيزو فارنج
بالايس.
بالايس طبعا. وفي بقى روتيشنال انجيوجرافي بره خالص القصه، بس طبعا انا ما جبتش سيره الحاجات دي عشان حسيت انها بره القصه، يعني مش موضوعنا يعني، بس كل ده اتعمل.
More questions?
Thank you very much.
The next speaker will be Professor Hani Fouad from Ain Shams University. He will speak about airborne infection during TEE, new techniques for
Okay, so this is something to relax with. It's not, it's like a sandwich between really transesophageal related things. It's more of epidemiology. Now, this is the list of common pathogens liable to airborne infections. And on the head of this list is, of course, SARS, COVID-19 comes on the top of the list because we are concerned, measles, influenza, and chickenpox. According to WHO, what's airborne? Airborne is transmission of infectious agents in the form of droplet nuclei that remain infectious when suspended in air for a long distance and time. ومسافة. This is a historical slide which we used to use about the complications of TEE. I mean, odynophagia, dental problems, perforation, laceration. And now this is something else. We are discussing airborne infection. There was a big debate as whether transesophageal echo is EGP is aerosol generating procedure. Is an AGP or not. Finally, they came to consensus that it can be released, possibly, it's a potential. Therefore, the recommendation is to treat TE as an EGP with COVID-19. This is where the source, COVID-19 is the cause, of course. So, all airborne precautions have to be taken, double gloving, gowns, face mask, the powered purified respirator, surgical cap, and face shield, everything. And there's something about intubated patients. Here, I'm going to differ with Sharif because here it's recommended that patients be intubated. The risk is greater in non-intubated patients due to possible because the patient may be hassling, he may cough, he may gag, so droplets are more liable to spread. So only the recommendation is to perform TE only in intubated patients. And it should be fast and goal-directed. That's why after that, the general anesthesia, it gives an advantage in patient already paralyzed and anesthetized. So, but you still have access to his secretions with the tube, and the movement of the tube is inadvertent by the transesophageal probe. The tube can still move and droplets can get out. Not only you as an echocardiographer, but the people surrounding you. So when the question was asked which TE could be cancelled, I was surprised to find that the American Society of Echocardiography recommends that all TEs should be cancelled or postponed in the era of COVID. Or used, I mean, you should ask yourself if you can use alternative imaging procedure, especially in non-intubated patients. This is a list of procedures to be done during the COVID-19. I just want to point to you, it's a very big list. Defer is written twice, defer and here again. I mean, they are trying to defer the procedure whenever they can. Defer or postpone and choose alternative modality of imaging. Now here is the, this is a diagram to show how you should repeat even the transthoracic echo before start and double confirm yourself. If needed, you should proceed to TE. These are the situations which TE is almost mandatory. You are in the surgery room, and there are 5 situations. Infective endocarditis with perivalvular and valvular involvement. Only type A dissection, not type B. Initiation of mechanical support, whether temporary or durable. Myocardial infarction with complications. Rupture free wall, rupture septum, and prosthetic valve assessment. The questions are, whom are we protecting? Of course, the staff. We are protecting ourselves and the seniors and the juniors both. The second question, whom are we to image then? As we said, these are the people to image in the slide before. And you should always ask yourself if there's an alternative imaging modality. And where to image? Is it in the room, bedside, or in the OR on the cath lab? How to image? Point of care ultrasound, POCUS, ultrasound assisted physical examination should be all done by the nursing or the people giving care to the patient before you proceed to your procedure. The protection is both personnel and equipment. Many procedures, starting by yourself, gloving, apron, masks, as I said, and then the machine, and then how to get rid of everything after you finish. The most important in these are donning and doffing. Donning is before you start the procedure and wearing everything, and doffing is how to get rid of everything after that. The most important here are, these points are very important. The most seniors should perform the 3E to do it fast and take it to the reading room, take the maximum number of video clips in the shortest period, and take it to the viewing room for his junior staff to teach. It should be a focused examination, or they call it pathology guided. أنا داخل أعمل إيه؟ ببص على إيه؟ بسرعة. The second thing in the machine, now there's the new thing here is that many companies are advertising for their plastic sheaths, and you should get the machine of everything except the TE probe. الكابل بتاع الاي سي جي والبروبز الثانيه والجل وكله بتاع، واللي بيشتغل المنظار مش هو اللي هيحط ايده على المكنه. Removal of all necessary unnecessary equipment, and after finishing you should choose a virucidal disinfectant recommended by the manufacturer. كل حاجه بتتشال من المكنه. مش بس بطهر الماشين، بعد كده الايكويبمنت، السكاننج باد، الاكزامينيشن روم، كل حاجه بتتمسح بالفيروسايدال ايجنتس، كيبوردز والنوب وكل حاجه، even the mobile phones. Ideal situation in to perform it in what type of room, or which room should be performing the TE in. Aerosol generating rooms all should be tested for air exchange. لازم يبقى ليها specification معينه، بيتحط فلتر اسمه هيبا فلتر، هشوف ده اختصار ايه. والفلو لازم يبقى ليه سرعه معينه، والفلتر لازم يديتكت ان دي نيجاتيف روم. This is the ideal situation. الروم should be left idle for 7 complete air exchanges، اللي هي بتدي فرصه لل 100% almost clearance before the next patient is in. دي حوالي من 10 ل 30 دقيقه بين المريض والتاني. دي elements of the air isolation room. They are many. الخلاصه ان الحته اللي فيها المريض بتبقى في السنتر، الهواء بيخش من الاركان وبتبقى نيجاتيف. لازم يبقى فيه مقاس للضغط جوه الاوضه، نيجاتيف بريشر روم، وفي اداره هندسيه بتتابع ده كل شويه. الهيبا فلتر ده اللي هو اختصار هاي افيشنسي بارتيكوليت اير فلتر. اي حاجه ازيد من 0.3 مايكرون بتتفلتر، ما بترجعش تاني، وده موجود في الاوض عشان خاطر يعدي فيه الهواء اللي خارج من الاوضه وما يعديش تاني على المستشفى، او يبقى ريسايكل تاني بس بعيد عن الهواء اللي داخل المستشفى. طب المستشفيات اللي ما فيهاش هذه الامكانيه للنيجاتيف بريشر، an air conditioned single room with an exhaust or well ventilated room is adequate options لو انا مش قادر اوفر النيجاتيف بريشر روم. الانتي روم هي الروم اللي بعمل فيها الدونينج والدوفينج، اللي بقلع فيها وبلبس فيها وبحط كل العده بتاعتي اللي انا هلبسها قبل ما ادخل على العيان، وفيها كل الحاجات اللي محتاجها الستاف، وفيها حوض للمريض وحوض للستاف مختلفين عن بعض، والديسانفكتنتس والسانيتايزرز. ده منظر لبعض الحجرات. والانتي روم هي دي اللي بيبقى فيها الخزين بتاعنا كله، واللوندري والهازردز، البايوميديكال هازارد. دي الحته النيجاتيف، وده البروتكتيف شيلد. نشوف اللي بعدها كمان. ده السيركيليشن بتاعت الهواء، تخش من هنا، وفي هنا في مونيتور بيمونيتور الضغط النيجاتيف في قلب الاوضه دي. الحمام قبل في الانتي روم، والهواء بيطلع ويلف في الهيبا فلتر، يخرج ويدخل من هنا وبيطلع بره المستشفى. Again another example of the air circulation. الاير فلو، positive air يخش من هنا يطلع من هنا والمريض مكانه هنا. That's my final slide. Thank you very much.
Thank you for this talk, but if a patient coming in emergency like AF and you want to cardioEgypt, and you have to do the TE for the left atrial appendage. What you will do?
هو الكلام اللي مكتوب انه you should control him first very well وتعملي ال throat swab تتاكدي من الفيرال ستاتس بتاعته. احنا طبعا كل الكونسيرن وكل الهيستوري اللي لقيته ده بالرغم ان هو في حاجات من 2013 و2010 منزلها سي دي سي سنتر اوف ديزيز كنترول، لكن الكلام كله كتر بعد الكوفيد. فانت بتعملي كنترول للريت وبتتاكدوا تكون المسحه طلعت الرابيد سواب. صح، ما عدا كوفيد والانفلونزا. الانفلونزا ما وارد ان هي تيجي، والتشيكن بوكس والميزلز ليها فاكسين. بس هو طبعا التاني بتبقى عندك المسحه وبتعمليها بقى اندر ديش سيركمستانسز، بتعملي كل حاجه. ما هم ده اللي قايلينه، انك انت تبقى عندك تشانس تبقى الكتيف، عمرك ما بتبقى في الامرجنت. هم الكبار الاربعه دول اللي هو البروستاتيك فالف رابشر في وول هارت، الليكج ان بروستاتيك فالف ديسكشن تايب اي مش بي بي في الاوت بريك. صح، الكلام كله ما بنعملش كده. لا
شكرا. Now proceed to the next speaker, Dr. Mahmoud Yasin. Right, rib implantation and TEE guidance pre, during, and post procedure.
Good afternoon, everyone. So in the next few minutes, we are going to talk about the role of transesophageal echo in transcatheter mitral valve edge-to-edge repair, or what we call mitral clipping. So as we know, edge-to-edge transcatheter mitral valve repair has been evolving rapidly in patients with severe mitral regurgitation who are at high risk for surgery or having a contraindication for surgery, and TE is crucial for identifying candidates for these types of procedures and for the feasibility of the procedures. And the added value of 3D transesophageal echo in these patients is that it allows for better evaluation of mitral valve geometry, more accurate quantification of mitral gorge severity, and real-time 3D transesophageal echo guidance during the procedure itself. So the first question we ask, who are the patients who will gain benefit from mitral clipping? Who should I refer for mitral clipping? Actually, these are the patient groups that has been tested who are proven to have benefit from mitral clipping. First, patients with degenerative mitral regurgitation who are declined for surgery, patients with severe LV dysfunction refractory to medical therapy, in addition to other patients like patients with severe heart failure, non-responders to CRT, and valvular heart disease with severe aortic stenosis and mitral regurgitation. And the most important groups are the first two categories with more than 400 publications on these patients. So mainly we are talking about patients with degenerative mitral regurgitation who are at high risk for surgery, and patients with functional or secondary mitral regurgitation with severe LV dysfunction who are as well high risk for surgery. So once we started this program at our center, and till now I receive phone calls for I have a young patient with mitral valve prolapse and severe mitral regurgitation. Should I refer the patient to mitral clipping? Definitely no, definitely no. Refer your patient for surgical mitral valve repair. This is class 1, because till now mitral clipping is reserved for patients who are at high risk for surgery or decline from surgery. So this is a structure of the mitral clipping. This is the handle and delivery system, and this is the mitral clip itself. It's composed of 2 arms, as we can see here, and grippers here. So the mitral valve leaflets go all the way in here. The first step is that grippers down to capture the leaflet between the arms and the grippers, and second step is arms closed to capture the leaflet again. So the leaflets are captured twice, once between the grippers and the arms, and one more time between the arms themselves. This ensures stability of the mitral clip. And this is a quick tutorial on how the clip is implanted. We have venous access towards the right side of the heart, right atrium, transeptal puncture to cross toward the left atrium. Dilator is introduced, through which a guiding cath is introduced, then introducing the delivery system, including the clip. Once the clip is entered inside the left atrium, it's bent towards the mitral valve to face the mitral valve. The arms are open to ensure perpendicularity towards the mitral valve annulus. I must dive in truly perpendicular to the mitral valve annulus. Then after diving and withdrawing the clip again to capture the leaflets, grippers down, arms up, and then assess the results. If I have satisfactory results, I can just release the clip, creating what's called double orifice mitral valve. So actually the principle behind the clipping is obtained from Alfieri stitch, the surgical stitching between the A2 and B2 scallop, creating a double orifice mitral valve, but performed percutaneously, of course. So the role of transesophageal echo in pre-assessment for patients undergoing mitral clipping, we can conclude it into three: identification of the mechanism of mitral regurgitation, estimation of the severity of MR, and finally anatomical assessment of the feasibility for clipping. First, regarding the mechanism, we have two patient categories, as we've mentioned. First, the generative MR, and when we call generative MR in mitral clipping, we mean mitral valve prolapse or flail. This is the generative MR in terms of mitral clipping. And second are functional mitral regurgitation or secondary mitral regurgitation in patients with dilated annulus and dilated cardiomyopathy, Carpentier class 1, or in patients with ischemic cardiomyopathy, Carpentier 3P. These are the two patient categories that we are working on. So this patient to the left here has flail anterior leaflet, as we can see, with severe mitral regurgitation. This is a DMR or degenerative MR, and the patient to the right has this markedly dilated left ventricle with impaired function, marked tethering of the mitral valve leaflets with low coaptation, resulting in central severe mitral regurgitation. This is an example of a patient with functional mitral regurgitation. So after identifying the mechanism of mitral regurgitation, we have to localize. It's not allowed anymore just to say the patient has mitral valve prolapse, sends the patient to surgery or mitral clipping. I have to localize the diseased scallop. If we are using 2D echocardiography, you can localize using multiple angles or TE views, or the easiest way is we obtain a sweep across the mitral valve, usually starting from the lateral aspect, the left atrial appendage. So the first scallops to appear are A1 and P1 scallops, and then with more sweep medially toward the mitral valve. When the aortic valve opens, this will be the A2 and P2 scallops. As we can see here, this is the maximum jet, and then more sweep medially towards the interatrial septum, we will get the A3 and P3 scallops, as you can see here. So by making just this sweep in a single TE angle, we'll obtain all the scallops of the mitral valve, and we can localize the diseased one. Or if we are using a 3D probe, we can get benefit of the X-plane function, where I can get the commissural view and put this X-plane line in the center of the mitral valve leaflets. This will get us the other orthogonal view, which is the A2 and P2 scallops, as we can see here. Then putting the X-plane medially, this will give us the A3 and P3 scallops. Putting it again laterally, we will get the A1 and P1 scallops. So by using only one view and moving the X-plane function, we can clearly see that this patient has obvious leaking in the A2 and P2 scallops or central scallops. This will be the target of mitral clipping. Or I can obtain a 3D zoomed mode across the mitral valve, getting it to the anatomical or surgical view, where the aortic valve is located at 12 o'clock and the left atrial appendage here at 9 o'clock. So now I'm sitting inside the left atrium and looking toward the mitral valve on the emphase view. So the mitral valve prolapse will be facing my eyes. So we can clearly see here the flail A2 scallop of the anterior leaflet, and putting a color will show us that the regurgitation is central, coming from the central scallops, of course. And we can also rotate this volume here to look at it from the LV perspective, and we can clearly see here the origin of the mitral regurgitation. The origin here is located between A2 and P2 scallop or central jet, and this will be the target of mitral clipping. Then the next step is estimating the severity of MR, and we can follow the guidelines exactly as we usually do in the transthoracic echo, with qualitative, semi-quantitative, and quantitative assessment, especially the calculating the effective regurgent orifice area and regurg volume. And if I'm using a 3D probe, I can get benefit of the 3D function, where I can also obtain a 3D colored mode across the mitral valve, and using it to get to the MPR mode, where I can plan across the neck of the mitral regurgitation in two orthogonal views to get the true on-face view of the mitral regurgitation. Then direct planimetry of this area here. This is the 3D vena contracta area, or 3D effective regurgent orifice area, and this is the most accurate echocardiographic method to quantify regurgitation if it's more than 0.4 centimeter square or 0.3 centimeter square in some cases of functional or secondary mitral regurgitation. This will be severe mitral regurgitation. So I have to confirm that this patient has severe mitral regurgitation and is a potential candidate for mitral clipping. So now, if a patient is a potential candidate for clipping, I have to assess the anatomical feasibility of the procedure, whether the patient has feasible anatomy for mitral clipping or not. So we have two specific measurements for patients with DMR and two specific measurements for patients with FMR, plus other measurements applied for both. So first, in patients with DMR or degenerative mitral regurgitation in flail or prolapse, the first thing we measure is the flail gap, which is the distance between the anterior and posterior leaflet in the maximum systolic phase. We measure the degree of displacement here. So we need a flail gap to be less than 10 millimeters in order to be easy to be grasped by the mitral clip. If it's more than 10 millimeters, it will be difficult to capture both leaflets together in the mitral clip. The second measurement is the flail width, which is the width of the flail segment, as we can see here. This is the width across the mitral valve annulus, and usually in the old practice we needed to have flail width of less than 15 millimeters in order to be grasped by the clip. But recently, with more experience we've got, so we are allowing for flail width for up to 20 or even 25 millimeters, because I can actually put more than one clip side by side as long as the mitral valve area allows for putting multiple clips, and I will not generate a iatrogenic mitral stenosis after the procedure. So we have two measurements for DMR, which are the flail width and flail gap. The two measurements for functional mitral regurgitation or FMR are the coaptation length. I need to measure the coaptation between both leaflets, and I need the coaptation length to be at least 2 millimeters. If the leaflets are widely separated from each other, it will be difficult to be grasped by the mitral clipping. And the second is the coaptation depth, which is the distance between an imaginary line across the mitral valve annulus and the tips of the mitral valve leaflets in the systolic frame. And I need this coaptation depth to be less than 11 millimeters in order to be feasible for mitral clipping. Now, the following measurements applies for both FMR and DMR. We measure the leaflet length. So I need the leaflet length to be at least 10 millimeters. This is a best case scenario, or at least 7 millimeters, but not less than this, because actually I need to grasp at least 5 millimeters of each leaflet. So I need to have a sufficient length of the leaflets in order to be grasped. Usually the anterior leaflet is long enough, but the main problem usually occurs in the posterior leaflet, may be shortened. So I have to check that it's more than 10 millimeters. The most important thing, we are creating iatrogenic mitral stenosis. So I have to be sure that the patient doesn't have a pre-mitral stenosis from the start. So I have to trace the mitral valve area, as we can see here, and ensure that the area is more than 4 centimeters square, and measure the pressure gradient across the mitral valve. It's not allowed to be more than 5 millimeters mercury. It should be less than 5 millimeters mercury, because if the patient has a mitral valve area of less than 4, or the pressure gradient is more than 5, so we are creating a significant mitral stenosis after the procedure. Then I have to measure the left atrial size, because at the side of the septal puncture should be about 4 centimeters above the mitral valve annulus, and we will talk about this in a minute, to be sure that the left atrial appendage is clear and no left atrial appendage thrombi. And actually, left atrial appendage thrombus is not a contraindication for the procedure, but I have to warn the interventionist not to pass wires inside the left atrium to avoid left atrial appendage, to avoid embolic complications. Then I have to check the interatrial septum, which is the site of the puncture, if it's thickened or not. So these are the feasibility criteria, as we've said. These are the feasible anatomy, and the contrary is non-feasible anatomy for mitral clipping, and I have to send the patient to surgery instead. So let's quickly review the intra-procedural guidance during the procedure itself. The first thing we do is to check the pericardial space and ensure that we don't have a pericardial effusion from the start, because if any effusion developed or even increased in severity during the procedure, this is a warning sign. I have to stop and check for complications. Again, check the left atrial appendage. So the first step in the procedure is the transseptal puncture. So I have to follow the needle while it's causing a transseptal puncture. We actually need a puncture to be posterior and more or less superior. And before puncture, we have to just tenting on the interatrial septum here. And before puncture, I have to measure the distance between the tenting area here and the mitral valve annulus. As we said, I need 4 centimeters in order for the delivery system to go inside the left atrium and allow for the navigation of the delivery system inside the left atrium. In some cases, this puncture may be a little bit high, about 4.5 centimeters in cases of myxomatous mitral valve and flail mitral with high coaptation. And in other cases, I may need just a little bit lower puncture, about 3.5 centimeters, in case of secondary mitral regurgitation with marked tethering of the leaflets and poor or low coaptation, but usually 4 centimeters is okay. So after confirming the position, the first is the dilator is crossing the wire is crossing the interatrial septum, and I have to ensure that the wire is passing to the left upper pulmonary vein, not passing inside the left atrial appendage to avoid injury. And then the guiding cath is introduced into the left atrium at this time, and I have to frequently monitor the site of the guiding cath inside the left atrium, because during the procedure, there will be excessive manipulation inside the left atrium, and this guiding cath may be slipped backward towards the right atrium. So I will lose all the support, and at this point, I have to restart the procedure from the very first beginning, from the transeptal puncture. So this is a critical case that I have to frequently monitor the guiding cath and ensure it has a sufficient length inside the left atrium during the whole procedure. Now the mitral clip is introduced via the guiding cath, and I have to dive into the left ventricle. As you can see here, I put a color doubler across the mitral valve to ensure that the clip is going toward the worst mitral regurgitation jet. As we've said, I have to dive towards the left ventricle with the mitral clip truly perpendicular to the mitral valve annulus. So if I'm using a 2D echo, I have two views, which is a commissural view and long axis view. To be sure that I am truly perpendicular to the mitral valve annulus, I must see the two arms of the clip open in the long axis view, and I can see only one side of the arm in the commissural view. So it's truly perpendicular. I can see two arms in the long axis view and only one side of the arm in the commissural view. Or by using a 3D echo, I can clearly see that the clip is not perpendicular to the mitral valve annulus. It's a very easy image to understand. All I need to do right now is just to clockwise rotate the clip a little bit to be truly perpendicular to the mitral valve annulus. That's what we did right now. So now the clip is truly perpendicular. I can reduce again a little bit in the 3D image to just see the mitral clip and ensure that it's perpendicular to the mitral valve annulus. Now the mitral clip is dived towards the left ventricle, and finally, after diving, I withdraw the clip again to capture the leaflets inside the clip. And the first step is the grippers down and then arms up. Okay, technical problem here. Okay, so the first step is grippers down to capture the leaflets and arms up, as we can see here. So after capturing the leaflets, what's the first thing to do? I have to assess, not mitral regurgitation. I have to assess first the grasping part of the leaflets. This is the first step I have to assess. So I'm measuring the remaining length of the leaflet to see how much length of the leaflets is grasped in the clip. So if I have, for example, 3 millimeters remaining and the initial length was 10 millimeters, so I'm grasping 7 millimeters of the leaflet, and this is sufficient. But if I'm grasping only like 2 or 3 millimeters of the leaflets, I have to reopen the clip again because the clip will not be stable. Okay, so the first thing to assess is the captured leaflet length. I need to capture at least 5 millimeters of the leaflets. What's the second step? To ensure that we have no significant mitral stenosis. So I have to put a color doubler across the mitral valve and trace the VTI, mitral valve VTI, to measure the pressure gradient to be sure that I'm not creating a significant mitral stenosis. So even before assessing the mitral regurgitation, I have to assess the stability of the clip first by the length of the leaflet capture and ensure that I'm not causing a significant mitral stenosis. Then the third step is putting a color doubler across the clip to see whether there is a significant residual mitral regurgitation or not. If I'm having a satisfactory result, I can release the clip. If not, I can reopen and reposition, or even I can put multiple clips side by side. If I'm getting a satisfactory result, then the next step is to release. Okay, and I'm putting the fluoro image here to see the needle here. This is the delivery system after releasing of the clip. It's like a needle, so it may cause injury towards any of the atrial walls. So I have to follow the needle while going out towards the guiding cath to ensure that it's not cause any injury to the left atrial wall or left atrial appendage. And this is the final result after clipping. Final result, just 30 seconds. Okay. Okay, this is the final result after mitral clipping. I'm creating an iatrogenic double orifice mitral valve, as we've mentioned before, and ensuring that the patient has no significant residual mitral regurgitation. The patient, this is mitral regurgitation jet, of course, yeah, but the patient has massive mitral regurgitation from the start, and now it's only mild mitral regurgitation. This is a very accepted result. And actually, after a while, this mitral regurgitation may fade away because the embolization will occur, and this mitral regurgitation will improve a little bit away. Thank you. Any questions? Sorry for crossing time a lot. Sorry about this.
Question? question دكتور any question؟ شكرا. شكرا.
يعني بالظبط.
The next speaker will be Professor Hani Mahmoud from Aswan Heart Center. He will talk about 3D TEE and TAVI, new modality of reconstruction.
Okay. Thank you so much. My talk is not going to be that much interesting like Mahmoud's talk. I'm proud to work with Mahmoud and Aswan Health Center. That's indeed because of Mahmoud is a very talented speaker. This is number one. Number two, that mitral clip is very TE dependent. TE dependent, 2D, 3D TE dependent. I cannot imagine doing mitral clip without transesophageal echo, but everybody's now doing a TAVI without even 2D TE guidance. That's why the 3D TE mainly is helpful during the planning of the procedure, not during the guidance, unless they expect problems, and then they call for us in the echo lab, and then the cath lab. But 2D and 3D TE can help in a lot of steps in patients' journey from the start, from aortic valve area calculation, the patient selection, choice of procedural access. By 3D TE and 2D TE, we can say this patient cannot do femoral access by some findings that we may see, as I will explain later. Prosthetic choice and sizing, this is the best or the most important added value for the 3D TE, and procedural guidance if they only call for us in the cath lab. So patient selection, starting from the aortic valve area sizing, which is not easy in many cases. 3D TE has a lot of added values because by 3D transesophageal echo, we can do planimetry of the aortic valve area simply by putting our MPR lines, multiplanary formatting lines, exactly at the tips of the aortic valve. Then we can see clearly the aortic valve area in an on-face view. And by tracing this, we get the direct planimetry of the aortic valve. And because these lines, we have the luxury of tilting these lines like this, like that. So it is not like the planimetry that we get for the mitral stenosis, that we have to have a very good window, and we put exactly the cut at the tips of the mitral valve by our probe. Here, even if the volume is tilted, still we can tilt these lines to put them at the tips. So I have all the luxury to put my lines wherever I want. Then we get the most accurate 3D planimetry for the mitral valve. This is number one. What about continuity equation? Everybody knows the major source of error in the continuity equation is the LVOT diameter, right? That's because the anteroposterior diameter of the LVOT is not usually the biggest. And sometimes the LVOT is not a circle, because the continuity equation based on the assumption that the LVOT is a circle. So they get a diameter, they square it, they multiply it by 0.875, you know the calculation, assuming that the LVOT is a circle. If the LVOT is not a circle, this equation is not valid. By the MPR, again, like what we did in mitral and in the aortic valve area calculation, we do this, but we put our lines at the LVOT level. And you can see, everybody in this room will know that this LVOT is not a circle, right? And unfortunately, the AP diameter is usually the smallest, okay? The transverse diameter is usually much bigger, or significantly bigger than the AP. That means the LVOT area that the equation will take from the AP diameter will be smaller than it should be. That will give us lower stroke volume, falsely lower stroke volume. And then we'll start thinking about low gradient aortic stenosis. But please, before that, this is not me saying that, the focused update of the American Heart Association, the assessment of aortic stenosis, tells you if you find discrepancy between the gradient and the continuity equation area, for example, area of 0.9, severe, but the gradient is not severe, the flow is not high, we will start thinking about low flow. They tell us, before thinking about this, remeasure the LVOT again, but by a 3D method, whether 3D TE or a CT or MRI. Anything that gives you the on-face view for the LVOT, you trace it, this is the area, and then you multiply it by the VTI of the LVOT. Then you will get the real stroke volume. And you will be surprised, like what happened with me, that many cases will go out from the low flow, low gradient category and then turn out to be only moderate aortic stenosis. Okay? So this is number one. For the anatomy, this patient was referred for me as to assess his aortic valve area because he is a rheumatic patient, basically because he's an Egyptian, and a young patient, thickened aortic valve tips, and some commissural fusion. But this patient with 3D-TE turned out to be a bicuspid aortic valve. And this is a raphe only between the none and the right, clearly bicuspid aortic valve, which has a lot of concerns during the TAVI procedure. These patients have certain types of prostheses that should be used, and some valves, sometimes the valves are actually contraindicated, or they use it as an offline thing. The axis selection. Transfemoral axis needs a very clean descending aorta and an arch like this one. But some patients with heavily atheromatous wall like this, especially if there is some mobile atheromas, will be of a big concern during transfemoral axis. 3D-TE in the descending aorta gives you a wider view. So that gives you the suspicion like an arrow-like atheroma standing in the lumen of the descending aorta. Imagine passing a big sheath beside this in the transfemoral axis. That definitely will dislodge and go somewhere. Luckily, this is descending aorta, so it will go distally because limb ischemia. But if that thing is in the arch, you know what will happen. Okay? So valve sizing, if I can say, the most important thing that 3D can help the patient during TAVI is the valve sizing. And that, of course, happens before the procedure, not during the procedure. Again, like what happened in the LVOT sizing, we'll do the same, but at the annular level. Because sizing is the most important step in the safety and the success for TAVI. They do this by CT, of course, but if the patient can't have CT because of renal problems, the only alternative solution is doing 3D-TE TAVI protocol to assess the size of the annulus, the sinuses, the left main height, everything we can do with the 3D-TE. Because undersizing, if, for example, if you give him an annulus, which is smaller than normal, than it should be, what can happen? The valve will be small, can migrate. Paravalvular leak can happen, right? And what if it is big? Sometimes they will not be able to pass it through the native valve. And if it is big, what can be occluded? Down heart block, the coronaries up there. And if the valve is too big, the valve will not take its full shape after they deploy it. So the leaflets of the new valve will not take their full shape. They will be wrinkled. So transvalvular leak can happen. So the small valve can have paravalvular leak. The big valve can have transvalvular leak. So a lot of problems. That's why sizing is very, very important. And we do this understanding the annulus anatomy. It's very complex, but for the sake of time, I will pass it. In 2D, we have two main problems. Number one, sometimes we have oblique cuts. You know that we have three cusps, and the bases of the cusps are lower down at the level of the annulus, where the commissural attachment at the level of the sinotubular junction. So in order to make sure that even in 2D you are cutting the major diameter of the annulus, we need to cut at one base and in one commissure. One base, which is the RCC, right coronary cusp, and the commissure on the other side will be higher up. In that case, you measure like this. Okay? This is how to measure in 2D the central diameter of the annulus. Not like this one. If you see a symmetrical base-to-base view, you know that you are cutting obliquely the annulus. Okay? So that may be a surprise for some of you. This is the view that we usually look for because it looks nice. But if you take this view, that you are cutting actually oblique because this is base to base and the base is lower down. If you need really to see the central diameter of the annulus, you need base to commissure. And in that case, you measure like this because this is the level of the base. This is the commissural attachment. You see the commissural attachment between the two leaflets are higher up at the sinotubular junction, not at the base. What is only at the level of the annulus are the bases, okay? So if you are seeing symmetrical view like this, that means you are cutting base to base. But you need to cut at one commissure, which will be higher up because it is there. And the other one is the base, which is lower down. In that case, you measure directly like this. Don't go for the sinotubular junction. This is number one. Number two, even if you are cutting in the center, again, the annulus is not a circle in many patients, right? And then you will underestimate the annulus. That's why they never believe us in TAVI in 2D. Give me one interventionist to give them, okay, the annulus is like this. And they will take it and size the TAVI procedure. Never they will do this. Because they know that the annulus, again, is not a circle in many patients, especially in elderly, which are the population for TAVI, the elderly patients. And studies show that the ovality of the LVT and annulus goes more towards the LV. So the annulus is oval, and once you go to the LVT, the ovality increases, the ovality increases, the ovality increases. So it is oval, oval, oval. Rarely it's a circle, okay? NPR doing the same thing using the CT. Instead of putting at the tips of the aortic valve or the LVT, now you put it at the annulus. And see this annulus, a bit oval again. And unfortunately, the transverse diameter is bigger than the anteroposterior diameter. So by tracing this, the software gave us two measurements. Give us the area and the perimeter, which is circumference. And you can measure the dimension, the diameter, minimum and maximum. By these numbers, they have tables. The TAVI guys have tables. If the average diameter is like this, if the perimeter is like that, if the area is like that, so the suitable size of the valve is that. This is exactly what happens in CT. Furthermore, we can measure the height of the left main. So the left main height in relation to the annulus by the NPR, by a stepwise approach. I put that video on the YouTube for those who need to know how to assess the annulus in 3D. So you can see the height of the left main in relation to the annulus. This is very important because for each prosthesis size, they need a certain height for the left main because if the prosthesis is very big and the takeoff of the left main is low, there is a risk of occlusion. So they need to know this very important. And that was proven by many studies that the 3D TE is comparable to the CT. Of course, CT is better. No doubt about this. But if the patient can't have CT because of renal issue, 3D TE is the alternative solution. And now we have even some softwares with some vendors that can give you modeling for the aortic root, sinuses, and the left main. All these measurements just it will come automatically with some vendors. Okay. During the procedure, a lot of steps, but now, as I told you, they don't call for us except if the patient doesn't need contrast. If they need to do zero contrast, they do the sizing by 3D TE and they call for us to guide them to position the valve and do everything. But if there is no problem expected, they do this fluoroscopically. But you can see 3D can help you sometimes. This is the case of migration of the balloon during deployment, okay? During the inflation of the balloon, that's another example of downward migration. That can happen sometimes if the sinotubular junction is small. It like sucks the balloon down. And that's an example from the guidelines. During the valve deployment itself, you can see full deployment, very good visualization of the annulus. And this is the stent of the valve, deflation. And then you can assess the whole thing and success of the story and success of the procedure. So 3D TE can be of great help from the very beginning. Sizing of the valve area, sizing of the annulus, patient selection, as you saw the example of the descending aorta atheroma, for example, and guidance of the procedure if they call for us in the cath lab. Thank you.